Hello everyone, welcome to the class of forensic medicine. The lesson is on sudden and unexpected deaths from natural causes, or sudden and unexpected natural deaths. Now we will introduce the deaths from cardiovascular diseases. My name is Li Rubo. The content of this lesson include the following diseases: atherosclerotic cardiovascular diseases, hypertensive cardiovascular diseases, valvular diseases, myocarditis, cardiomyopathy, aorta aneurysm and dissecting, cardiac conducting system diseases, and pulmonary thromboembolism. The diseases of cardiovascular system account for major cause in sudden unexpected death in doubt. Coronary atherosclerosis is the most common cause of sudden cardiac death. The incidence increases with age, largely due to increase in the incidence of coronary atherosclerosis and acquired cardiomyopathy. Around 70% of SCD is due to coronary atherosclerosis in adults. Coronary artery include left coronary artery and right coronary artery. Left main coronary artery is consists of left anterior descending branch, diagonal branch, and left circumflex branch. Right coronary artery consists of posterior descending branch, posterior branch of left ventricular, right marginal branch, right chorus artery. 1. Coronary insufficiency from narrowing of the lumen major vessel may lead to chronic ischemia and hypoxia of muscle distal to the stenosis. If the ischemia region involves the pacemaker node or major branch of conducting system, the liability to rhythm abnormality is increased. 2. Ulcerative abdominitis plaque may rupture, filling with vessel partially or completely with cholesterol, fat, and fibrous debris. The endothelial cap or ruptured plaque may act as wall within the vessel and cause complete construction. Subinitial hemorrhage, where bleeding occurs into a plaque, expanding it solidly and often reducing or blocking the lumen. Here is the coronary atherosclerotic plaque with reduced lumen of left anterior descending branch in left coronary artery. Here is the histopathological changes of coronary atherosclerotic plaque with reduced lumen of left anterior descending branch in left coronary. Here is the histological changes of coronary atherosclerotic plaque with reduced lumen of left anterior descending branch in left coronary artery, and the thickening of the wall with cholesterol crystal and the focal calcification. Here is the histological pathological changes of coronary atherosclerotic plaques with no lumen for coronary artery. Occlusive plaque and chronic total occlusion may be composed of fibroatheromatous plaque or fibrous. 3. Less than 1/3 of sudden cardiac death has been detected to have coronary thrombus at autopsy, as poor stenosis and complications of atheroma are much more common. Thrombi are still frequent and are often associated with myocardial infarct. Multiple thrombi also occur, some being post-infarction due to stagnant circulation. 4. Myocardial infarction occur with a severe or complete conclusion occur in the coronary artery, and if the collateral circulation is not sufficient to maintain the muscle. If 70% or more of lumen of major branch is blocked, infarct commonly develops. The effect of a larger infarct is either to reduce the cardiac function because of pump failure, as the necrotized muscle cannot contract, or it leads to arrhythmia and ventricular fibrillation. Here is the histological changes in acute plaque erosion with thrombus, in organizing thrombus with acute platelet-rich thrombus. Left picture shows the pale area at the lower edge is a regional myocardial infarction of several days duration. Right picture shows hemopericardium due to rupture and anterior myocardial infarct. That was due to cardiac tamponade. Here is the histological changes of regional myocardial infarction of several days duration. 5. Rupture of myocardial infarct. A rupture with myocardial infarct may cause sudden death from hemopericardium and cardiac tamponade, most commonly found in old patients who have soft senile myocardium but can occur in anyone. Tend to take a pill 2 or 3 days after onset of infarction when the necrotic muscle is becoming soft. Neurothrombosis may develop over a inner surface of myocardial infarct. Parts of it may break off, leading to emboli in the systemic circulation, which may cause infarct in kidney, spleen, and brain. Here is the rupture of myocardial infarct with myocardial hemorrhage resulting in cardiac tamponade. 6. Myocardium fibrosis. Another complication of myocardium infarction is the myocardium fibrosis, which may develop when myocardial infarct helps. Larger plaque on the endocardium or in the wall of ventricle or septum may later interfere with the cardiac function or with the conducting system. A larger fibrotic area on the free wall of left ventricle may later swell due to the higher pressure during systole, forming cardiac aneurysm, rarely rupture as they are soft and fibrotic. 7. Papillary muscle rupture. This can occur due to infarction and necrosis, allowing parts of mitral valve to prolapse with sign of valve insufficiency and perhaps sudden death. Here is the focal myocardial fibrosis in the ventricular septum. Here is the macroscopic focal myocardial fibrosis in the ventricular septum. Second, the hypertensive cardiovascular diseases. This condition may lead to sudden cardiac death from left ventricular hypertrophy. In hypertension, the heart may increase to 600 grams or more, and the muscle mass outgrow its coronary supply, even if the coronary arteries are healthy. Atheroma is often associated with hypertension, so that enlarged muscle mass is further deprived of even normal flow and becomes ischemic. Such muscle is unstable and irritable and easily jump into arrhythmia and fibrillation, which cause sudden death of individuals. Hypertensive cardiomyopathy with concentric left ventricular hypertrophy. Anterior aspect of heart and short axial slice at right. Double area so thickness ventricular wall more than 1.5 centimeters. 3. Valvular diseases. The most common valvular disease causing sudden death is aortic stenosis. In children, sub or supravalvular aortic stenosis may cause sudden death, whereas in adults, both continually bicuspid and calcified tri-leaflet valves are the causes. These conditions account for approximately 2% of sudden death in adults. Mitral valve prolapse is another uncommon cause of sudden death. The lifetime rate of sudden cardiac death in patients with mitral valve prolapse is around 1 to 3%. Mechanism of ventricular arrhythmia and sudden death include heart failure from severe regurgitations. The small vessel diseases at the base of heart with secondary ischemic license is the crest of ventricular septum. Here is the aortic stenosis nodular calcific time. There are nodular mass distorting the valve leaflets. Here is the mitral valve prolapses. 4. Myocarditis. Inflammatory myocardial diseases as the cause of death is most frequently seen in infants and children as lymphatic myocarditis, but occurs in adults as well. In young adults, sarcoidosis, which may be considered a form of granulomatous myocarditis, accounts for a small proportion of sudden death. Here is the cutting surface of left ventricle and the ventricular septum of myocarditis, male in color. Here is the lymphocytic myocarditis. There is extensive lymphocyte infiltrate and myocyte necrosis. 5. Cardiomyopathy. Cardiomyopathy, where a larger heart shows certain abnormal characteristics, including hypertrophic cardiomyopathy, huge hearts of over 1,000 kilograms, asymmetric massive thickening of the ventricular walls, congestive cardiomyopathy, or dilation of the chamber with thinning of ventricular walls, restrictive cardiomyopathy, evidence fibrotic thickening of endomyopathy, and arrhythmogenic right ventricular cardiomyopathy, displacement of myocardial fibers by fatty tissues and collagen fibers. Here is the hypertrophic cardiomyopathy, asymmetric left ventricular hypertrophy, small left ventricular chamber cavity, left atrial dilation, thickening of the anterior leaflet of mitral valve, and the evidence of left ventricular outflow tract obstruction are all gross features of hypertrophic cardiomyopathy. Here is the dilated cardiomyopathy. The autopsy diagnosis of dilated cardiomyopathy rests on the identification of cardiac dilation and the evidence of significant atherosclerotic and valvular diseases. Here is the restrictive cardiomyopathy. Here is arrhythmogenic right ventricular cardiomyopathy. Pathologically, the right ventricle is often dilated with focal thickening. Here is the arrhythmatic right ventricular cardiomyopathy. The histologic hallmark is that of fatty changes with myocyte alteration of vacuolization and degeneration. Chronic inflammation is common, suggesting a healed myocarditis. 6. Aortic aneurysm and dissecting. Acute aortic dissecting is serially life-threatening medical emergency. Aortic dissecting can cause sudden death, accounting for approximately 2% of natural sudden death. Aortic dissecting are classified by the size of intimal tear and by extent of dissecting hemorrhage. Dissection with intimal tear in the ascending aorta frequently extend distal to arch as far as iliac bifurcations. The intimal tear is typically in the ascending aorta, and the dissecting pile can extend it into the descending aorta, the arch vessel, renal artery, iliac artery, and mesenteric artery. Here is the intimal tear in the ascending aorta. 7. Cardiac conducting system diseases. Abnormal findings include dysplastic changes of atrioventricular nodular arteries, which have been associated with sudden death. The fibrosis and really necrosis of myocardium in the crest of ventricular septum. The later change have been seen both in isolated small vessel diseases at the base of heart, as well as small vessel diseases associated with mitral valve prolapse. In patients with heart block, either acquired or congenital, there will be scarring in the area of node and the branching bundle. Here is the cardiac conducting system diseases. abdominal findings in sinoatrial node artery infiltrated with fatty tissues. 8. Pulmonary thromboembolism. Overall incidence of pulmonary embolism is estimated from 23 to over 200 per 100,000 population annually, both for fatal and non-fatal cases. It has been estimated that pulmonary embolism is the cause of death of 0.2 to 5% of all people. Pulmonary embolism is considered the cause of death when extensive or when there are comorbid conditions with peripheral embolism without other cause of death. Emboli present in the main pulmonary trunk or in the proximal right or left pulmonary arteries are considered a cause of death. Digital emboli may be considered a cause of death if there are underlying conditions that contribute to death, but are not considered a definitive cause of death. Massive pulmonary embolism denotes obstruction of either of main pulmonary arteries or more than 2 labor arteries and is considered invariably fatal. Grossly, a recent thromboembolus is usually cylindrical and take the form of containing vessel and not a pulmonary artery. There is a wide variety of patterns of pulmonary embolism, but there is predisposition to right lung and the lower lobes, and multiple emboli are the rule. The end of emboli are removed at autopsy are blunt and the surface is smooth. Here is the histological changes of pulmonary thromboembolism. Okay, that's all for this lesson. Thank you very much.